All right, I'm going to introduce you to Dr. James Frame, our medical director extraordinaire for PERCOM and PERCOM Kilgore College Consortium, and he's finishing up, I hope, part 3 of respiratory emergencies, although if you guys keep asking all these exciting, wonderful questions, it may end up going to part 4. I know Dr. Frame would love that. And if at any time that you feel like you want to ask a question, the best thing to do is to unmute your mic unless you don't have a mic. Speak briefly and then be sure and remute your microphone so we don't catch your background noise on the video and disturbing the other students. If you do not have a microphone, you can type into the side, but it may take a little bit longer for us to see that. So without further ado, Dr. Frame, go ahead. I'm letting you have it now.
All right, very good. Well, this is hopefully 3 parts. What we're discussing today is the final end of the respiratory emergencies topic. My opportunities to review the questions for the National Registry, I also added a couple of slides as of yesterday to help us with respiratory failure versus respiratory insufficiency and having a difficult time breathing as opposed to respiratory failure and such. So there are a couple things we're going to go over. This won't go the full hour. It has the last 2 times. We've had a lot to talk about. Of course, there's a few questions which I thoroughly entertain and appreciate you guys asking the questions to begin with. I want to make sure this material is very clear so when you take the National Registry, there's no surprises. All right, to start out, we covered asthma, chronic obstructive pulmonary disease, and chronic bronchitis, and we finished out the second evening with the pneumonia pathways and how to go about treating them, including some of the bronchiolitis and RSV croup and such that we also talked about, especially with the pediatric emergencies. And now we're going to move on to some tidying up, if you will. So today we're going to start with toxic inhalation. And if you jump down to the bottom, the rule number 1, rule number 2 is 2 rules that appeared on the National Registry exam, the ones that I reviewed yesterday. Version 1 through 4 is out right now. Version 5 is ready to come out. It's a 1,000-question test bank. And at any time when you sign in for the exam, it pulls down questions from the test bank in a certain percentage: trauma, respiratory emergencies, airway management, EMS operations, etc. And you get a random smattering of them, but the emphasis is always on, when the emphasis comes into play on toxic inhalations and EMS operations, rule number 1 and rule number 2 seem to be the ones that were popping up the most on any of the questions that were proffered for the bank. So what you're seeing at the bottom there are 2 rules that you really need to commit to memory, not verbatim, but rules that you need to commit to memory to know that anytime your partner goes down on the scene of whatever, you call a backup ambulance to take care of the previous patient and you immediately start taking care of your partner. Second is, whenever you're in a toxic inhalation situation, you're the one that has to be protected first. You don't rush into these toxic inhalation environments and grab a patient, pull out. One of the most dangerous things that you can do is to 2 and 3 victims, especially with you guys being the paramedics, supposed to be treating the 1 patient. Now there's 3 patients for non-paramedics to be treating. I think you can see that this would be a quagmire. So as you approach the scene of any suspected toxic inhalation, or if you approach the scene of a man down and you find that they're in a hazardous material type situation, the correct answer is either wait for the incident commander or with the set of binoculars, try to view what may be causing the man to go down to begin with. Sometimes the DOT placards are on the side of the barrels and such, or in the building, that you can visualize clearly from the outside, and you get a better idea what's going on. And you may have to wait for the fire department to get there so that they can get their self-contained breathing apparatus, or even type A, self-contained sealed outfits on so that they can enter a material incident. You see this a lot in questions when it comes to EMS operations on the National Registry for Paramedics, when it comes to multiple people lying down on the ground as you pull up. And that most certainly gives away a toxic environment. Anyway, you can see these inhaled steam chemicals, toxic products, superheated air and such, but we're mostly focusing on the toxic products. In other words, the chlorine gases, any gas that can displace oxygen, and chlorine gas is probably the quintessential example of test questions that you'll see, because chlorine is heavier than air, so it tends to sit in lower basin areas. So people who are down low or at the bottom of a hill of an incident, such like they're going to be more susceptible to the poisonous effects of these gases. So on any question that you do, bottom line is, number one, if anything happens to your partner, you treat your partner and call for backup to have other people come in and take care of the original patient that you and your partner are taking care of. You'll always watch out for your partner first. And then second is, you'll always move a patient out of a hostile environment into a warm zone or a cold zone to treat them out there. You don't treat these people in the immediate zones, the hazardous zones, or the hot zones. Remove the patients before you begin treatment. All right. Next slide. Let's see, scene safety. The ABCs about securing these patients' airways, breathing circulation. Just remember that anything where inhalant abuses may take place, you're going to run into a patient which could very well be hostile or combative. These are the people that spray the inhalants into a plastic bag and inhale it, or they spray the ether that's in some of these cans into an enclosed environment and take real deep breaths to get their highs, if you will. Well, some of these propellants that they have can very well cause hallucinations, or worse yet, cardiac dysrhythmias. Again, the ethers and such, and some of the old propellants that they use for spray paint cans and such have a distinct chemical taste and odor to them, and you'll be able to pretty well pick that up when you get on the scene. If you get down close to the patient, just take a small whiff. You can kind of see if there's something on their face. Most of the time we take Kleenex, we wipe their face, and we smell the Kleenex so that we don't get the full toxic effects of it. At any time that you suspect that there's something like this going on, depending on how combative the patient is, the ABCs are really going to come into play. Importantly is going to be your scene safety. These patients, again, can get very violent, especially if they've mixed them with other chemicals as well. It's not too many adults that take, $1,000 cocaine packages and mix it with a $2 paint can. I mean, you're not going to see that, but you're going to see some less than brilliant people out there come up with some creative ideas on how to do K2 in addition to doing a spray can propellant, and get the ether effects from it as well. And more likely than not, you're going to arrive on the scene, you're going to find somebody in real deep trouble as their cardiac dysrhythmias, their chest pain, their respiratory failure come about as a result of mixing these toxic chemicals together. So you can, in fact, restrain these patients if their combativeness seems to be something that you and your partner can overwhelm. But in some of these cases, you're going to have to try to get an injection to these patients to calm them down even more and risk respiratory depression or respiratory arrest. You don't have a choice in those matters. These patients are violent. They can hurt a lot of people, including you and your partner. So if you give these type of injections and you look like they're spinning down the drain, hey, you know what? You're red-patched paramedics. You're trained on handling the airway. You drop an ET tube into them and they come into the hospital. You explain what happened, and we're all going to congratulate you for being great paramedics about it. Nobody got hurt, and the patient's safe because they got an ET tube in them. I'm good with all that. Just remember that on any EMS operation scenario, when you're removing patients from a hostile environment, it's not always toxic gases that are killing these people. It can sometimes be a toxic solvent. for instance, in any hardware store, or if you get out into rural areas of the country where farming equipment are bought and sold, the organophosphates, the insecticides and such like that can spill and get on a patient's clothing and give you the organophosphate poisoning that you're used to seeing in patients that are going to require large doses of atropine to keep them alive. More times than not, these patients are going to have a liquid spill rather than a gas spill, and as a result, they're going to still have this stuff on their clothing. It's going to be up to you with your BSI in place, of course, to have your vinyl or rubber or latex gloves on, then start removing the patient's clothing and washing them down pretty aggressively. I wouldn't fire up 1,000 pound per square inch pressure washer hose or anything and spray them down. Hell, you'll slice them to pieces. But you can certainly get a garden hose or even a gentle stream fire hose on these patients to start diluting out that solvent so you can get their clothes off and get that stuff off their skin. That includes rolling them over on their sides. More likely than not, they're laying in this stuff. So on your exam, the National Registry exam for paramedics, when you run into a situation of liquid solvent, don't forget to have your BSI on and then to wash these people down very thoroughly with a lot of flush. All right, that's going to be the answer to your exam. You're going to start popping some supplemental oxygen on these people. You're probably going to bypass and go right to the non-rebreather mask with a reservoir on it so that they can't exchange air with the outside and such and get some of that solvent in them. You're going to go right to that 15 liters. And that will probably, in this particular case, especially organophosphate poisoning, at least keep the patient cognizant enough so that you can explain to them what's going on, get the IV started, get the atropine in, and get them over to the hospital as soon as possible. So solvents are a big problem. You're only going to see one question on that. If you see one at all, it's only going to be one question. EMS operations, when it comes to poisonous, toxic environments, usually revolve around the air, the chlorine gases and the phosgene gases and some of the ammonia from the old refrigerants and such that were used prior to Freon being invented. You're probably going to get a question like that. So be familiar with how you approach those scenes and then how to remove those patients in what we call an emergency move out of the environment and then getting them treated. All right. Hey, that's okay, Ben. You missed the toxic inhalation piece. No big deal. It'll be posted on the PERCOM website, and you can review it at any time that you'd like. All right, we move on to pulmonary embolisms. Pulmonary embolism arise from thrombi that originate in the deep venous extremities. A certain percentage of them can come from the pelvis as well. But most of the time, the patient's going to have their blood clot flip up into their lung because of a clot down in their leg. They can originate in anywhere else. The pelvis and the lower extremities account for an overwhelming number of these thrombi. It's not so important that you recognize where these thrombus come from, although being able to recognize that they come from the legs will at least give you a clue as to what's going on with the patient. What's important is that you recognize pulmonary embolism. The number one cause of death, of sudden death in this country, is cardiac arrest. The second most common cause is massive pulmonary embolisms. Both of these can be treated if they're recognized very quickly. It doesn't mean you're going to save them all. It just means that if you can recognize it very quickly and start directing your therapy towards it, for instance, PEA, a huge problem with pulmonary embolisms, then at least you can get a good head start on it. Now, seeing that you're being called to an EMS scene and the patient's already collapsed, you're already way behind the 8-ball. But getting on the scene, being able to recognize with the IV fluids, the epi-pushes, the intubations and such, and hustling them into the hospital so we can give thrombolytic therapy to dissolve those clots, I think is going to put you way ahead of the curve. On the National Registry exam that you'll all be taking to become red patched, to become paramedics as your final step, The questions that surround pulmonary embolisms have to do with the patient who has suddenly collapsed and is now in PEA. And so you're going to slide right into your algorithm for pulseless electrical activity. It's one of the 4 H's. It's one of the differential diagnoses of PEA. So they may ask you the question about a 68 or a 70-year-old male or female who has been on blood thinners in the past, collapsed, just suddenly collapsed, not breathing and such like that. What do you suspect? Here's the rhythm strip. What do you suspect? And you suspect, well, you see that there's the sinus rhythm, but under big bold letters, there's going to be no pulse. And right then and there, PEA should alert you to the fact that a pulmonary embolism is at play. So that'll be a patient who's either suddenly collapsed or a patient who's having extreme shortness of breath where they can't even talk with you. Treatment, if they can't talk and they're having extreme shortness of breath, is just to get them right down with RSI and intubate them right then and there. No matter what your drug of choice is, all of them are going to be okay in this situation. Just get the patient intubated. So we know that the clot that comes up from the leg, if it's a small piece, it'll get up through the right atrium, right ventricle, go into the pulmonary artery, and then hits the bifurcation. It can go one of two ways, left or right. Not a lot of magic there. But if it lodges into one lung, your chance of survival of these things are tremendously high if recognized in a timely manner. And that includes the emergency department as well. We can give thrombolytic therapy, the therapies that we use to dissolve clots, like we do with heart attacks prior to PCI coming in, and angioplasties and all the other happy stuff that we got. Well, this same medication, TPA, that we use for strokes can be used for pulmonary embolism as well if the patient's having hemodynamic compromise. So low blood pressure, high pulse rate, high respiratory rate, low pulse oximetry, pleuritic pain. These are all the cardinal signs of a very stable pulmonary embolism. Every once in a while, you get a large blood clot that travels from the leg that goes up and it lodges itself right in the bifurcation, right in that fork in the road between the left and the right pulmonary artery, in which case then it blocks off all circulation to the lungs. And of course, that's the sudden deaths that we're talking about. Those patients collapse and are pretty much dead before they hit the ground. There's just such an interruption of blood flow. No blood gets pumped anywhere. The patient, instantaneous syncope and instantaneous cardiac arrest. So those we're not going to be able to do much about. All we can ask is that these patients follow with us very closely, and then as soon as their legs start getting warm, swollen, and tender, start getting themselves into the emergency room. We ask that people who fly on airplanes or take long car trips and such are going to be sitting down for a long period of time. Geez, folks, at least take an aspirin a day while you're in the car or while you're on the aircraft, you know, the day before and then the day of the trip and such like that, to at least reduce the possibility of blood clot formation in the legs. These are people who are susceptible to them. All right. So continuing on with PE. Oh, that's cute. All right, well, didn't mean to do that, folks, but the classic presentation is, yeah, I was sitting here watching TV and all of a sudden I got this real bad sharp pain in my chest, or I got this dull ache, or I got this burning sensation in my chest. It hurts like hell. What were you doing at the time? I was just sitting on the couch watching TV. I wasn't doing anything. I was in the workshop. I was doing laundry. Whatever I was doing, all of a sudden it hits me real hard, short of breath and hypoxemia. This is why patients get EKGs no matter what. If you suspect chest pain, shortness of breath, difficulty breathing, what's the first thing you're thinking about? You're thinking about cardiac, obviously. And then you get the EKG and it's showing sinus tachycardia, but there's no acute ischemia or injury patterns. There's no intraventricular conduction delays, which are brand new. There's nothing on the EKG except sinus tachycardia. You get the occasional classic S1Q3, T3 EKG findings, which are classic for PE, but just because they're not on the EKG doesn't mean it's not present. The S1Q3T3 is exactly that. It's an S wave in lead 1, Q wave in lead 3, T wave in lead 3. The T wave is either inverted or it's flattened completely. So the S1Q3T3 is a pattern that has not been tested on a while in the National Registry. So I wouldn't give it any more thought except to say we're on the scene of a real patient one day and you kind of see that pattern in a person that you haven't been able to figure out the chest pain. This may be a great way of saying, hey, we got a suspicion for pulmonary embolism. Now, the hypoxemia, the shortness of breath with the hypoxemia is very important. And that hypoxemia is the most commonly found sign in a patient with pulmonary embolism. These patients are pretty sick. They've had an abrupt cutoff of a certain amount of blood flow to the lung, and as a result, a certain part of the lung is not able to aerate that blood that's going to that or trying to get to that area but can't. Therefore, the patient's capacity to oxygenate their blood has been reduced on the size of the clot. If it's a big clot, you could wipe out the entire lung. A sudden 50% cutoff of your ability to oxygenate blood is usually a fatal incident. So it's going to be incumbent upon the paramedic to recognize, hey, we got something real bad going on here. They're really hypoxemic. They may have flipped a blood clot. Let's get this patient RSI'd and tubed and hyperventilate the bejesus out of them. Get that oxygen going. We'll deal with the low carbon dioxide. We'll deal with the acid-base shifts and such like that at the hospital. Your job is to get them hyperoxygenated so that we can have some sort of shot at saving this person's life until I can get the thrombolytics into them. Keep in mind that when you reduce a person's oxygen tension in their bloodstream by 50%, their brain's being affected, and they could very well go into stroke-like symptoms. In other words, global, because they don't have enough oxygen. Be the same as strangulating them. I mean, 4 to 6 minutes, and their brain is going to be pretty much damaged beyond repair, and certainly be on any kind of meaningful recovery. Oh boy, we got the woodpeckers back here. Okay. Okay. The third one is going to be very important. Not all patients will come to you saying, I've had sudden onset chest pain with shortness of breath, difficulty breathing, hypoxic, I'm sinus tachycardic, blah, blah, blah. Some of them are going to say, you know what, over the past couple of days, I just haven't been feeling well, and I've been short of breath, and I'm not even able to walk across the room now. And a couple of days ago, I was working just fine, and now I'm just really slowing down really big time, and I really feel short of breath, and I feel like I can't catch my breath. I feel like every time I want to take a deep breath, I can't. These are also suspicious signs and symptoms of pulmonary embolism. They could mean congestive heart failure, right ventricular heart failure, a worsening pneumonia, or a slowly but surely collapsing lung. This medicine stuff can get real complicated real quick on you. And so what you have to do is have a high index of suspicion. Geez, if this person's short of breath with difficulty breathing, get a little bit more information from them, part of your sample history. What brought this on? How long has it been coming on for? And what medications do you take? Look, if they're on Lasix and digoxin, so 12 other type of cardiac medications, and their legs are edematous, 2 and 3 plus pitting edema and such, and they've been getting a slowly progressive shortness of breath. Yes, it is probably congestive heart failure, but don't forget it could also be pulmonary. Patients that have edematous lower extremities with a lot of water down them and such like that don't have much capacity for venous return and such, and that blood can pool, and it can cause lower extremity blood clots as well. So don't assume everything is the way that it is. Go ahead and treat them for the heart failure. If you hear rales in their lungs, then you've probably got the diagnosis. It all comes down to physical exam here. If you're hearing the rails in the lungs, go ahead and treat for congestive heart failure. You're seeing a lot of edema in the legs, go ahead and treat it for congestive heart failure with pedal edema. But if you don't have a clear explanation for the shortness of breath, difficulty breathing, yeah, my legs are fine, they don't swell, been keeping up with my medications and such, don't just assume it's a CHF. You have to consider pulmonary embolism. Again, treatment, get them oxygenated, and keep them going until you can get them to the hospital here. We run them through a CT scanner and see what they call a CT scanner. We're able to see if they've got a pulmonary embolism or not pretty quickly these days. We don't have to do it the old-fashioned way where it took 3 hours to figure it out through an old BQ scan. So if you don't have, again, as the last one says, if you don't have a clean explanation for what's going on with the patient, they're short of breath, be thinking PE. Remember, it's the #2 cause in this country for sudden death. All right, so let's talk about the symptoms again. This time I've got them listed based on how often they occur in patients. And you can see tachypnea, rales, and hypoxemia are your 3 big ones. With tachypnea, greater than 16 per minute being the big one, followed by rales. Now the rales may or may not be present. 58% of the time they're present. They put that pulmonary embolism hits the pulmonary circulation so hard that the blood is cut from going to that particular lung. Blood has to go somewhere, so it backs up and puts a big strain on that right ventricle. That's called cor pulmonale, and that puts the patient in right side congestive heart failure. So they can get some rales with it, but it's not an impressive amount. They start backing up their blood into the superior and inferior vena cavas and then down into the liver and such. And if this has been an insidious process, in other words, occurring over a period of hours and such, they could start getting sudden onset of swelling in their legs as well from all the dependent edema. But for the patient who comes in with acute onset of these symptoms, you have to be worried about the tachycardia, tachypnea, the rales, and the hypoxemia. They're going to be your biggest symptoms that are going to show up. And so the patient who's breathing real fast when you get on the scene, who has risk factors for pulmonary embolism, be thinking pulmonary embolism. On the National Registry exam for the paramedics, they're going to make it much more clear than just a very innocuous comment about tachypnea and expect to come up with a PE diagnosis. What they're going to do is give it to you scenario based, more likely than not. And they're going to show you that they're going to tell you within the question if this patient's tachypnic and they're hypoxemic, they're tachycardic, they're complaining of pleuritic pain, and oh, by the way, they've had some leg swelling. The National Registry is not interested in tricking you, or in other words, trying to blindside you, or trying to make things so difficult that you can't possibly come up with the answer. They make the question patterns so blatant that you cannot come up with any other choice except to say this is pulmonary embolism when they give you 5 of these symptoms here. I mean, and the scenario is going to say, and the patient has this history. So you're going to get a pretty straightforward history. It'll be the classic history: the pleuritic pain, the shortness of breath, the difficulty breathing. I just took a long car ride. I just got off an airplane 2 days ago. I ran out of my Coumadin that I was on for my atrial fibrillation a week ago. Anything that has to do with stasis, in other words, blood pooling. And I do that when I'm sitting down. I do it when I'm on an airplane. I do it when I'm driving a car. I've been treated for this before. I was on Coumadin, but I got better, so I stopped taking my Coumadin. Those are going to be the 3 biggest fact patterns related to pulmonary embolism, and only those 3. You're not going to see another fact pattern related to that. So if you see the car, the airplane, or the fact that I stopped taking my Coumadin, my blood thinner, my warfarin, be thinking PE. And then, of course, you're going to have to go about the treatment. All right, so what are the risk factors? We already talked about immobilization. Travel of 4 hours or more within the past month. Been on any long car rides, airplane trips, such like that. Immobilization, the patient is in a nursing home. The person that had the fractured femur that from a car wreck or fractured pelvis that is now on home therapy and is just starting to get around, it's just starting to do some physical therapy. Well, hell, they've been on their back for almost 4 weeks with the femur fracture and such in traction. They're at huge risk for pulmonary embolism. Anybody with cancers, especially the lung cancers, can be a setup for blood clots, because one of the problems with cancers is it causes a state called a hypercoagulable state. In other words, the blood clots faster than the normal person's blood does. And if it's pooling anywhere, it's going to clot up real quick. Malignancies are famous for this. And then, of course, if they've had a previous history of any kind of varicose veins, thrombophlebitis in their lower extremities and such, trauma to lower extremities and pelvis in the past 3 months, we covered already. Smokers, they're pretty much at risk because of the chronic vasoconstriction that person insists on doing to their blood vessels. And there comes a point in time where they're constricted from the nicotine so much that they actually can form blood clots as well. And of course, just the presence of the nicotine can cause some endothelial damage. In other words, damage to the inside lining of the artery. And instead of being a nice, smooth, frictionless surface where blood just glides along, now you're putting these little pock marks in there that platelets can get stuck in. And actually, you're forming clot over a period of a month, 2 months, 6 months. And then you've got bigger problems. Okay, so again, mainly supportive treatment. Get them on some big time high flow O2. If they become hemodynamically unstable, you're going to have to intubate them so that they don't crash and burn on you. It can be an elective intubation under elective conditions, or you can make it a 5-alarm emergency and wait for them to go into cardiac arrest and vomit all over the place and such. And now you've got yourself a much more difficult resuscitation. Your job as paramedics is to intervene when possible and react should something real bad happen. Don't wait for bad things to happen and then be in a total 100% react mode. If there's a chance for you to intervene before they get to that last point, intervene. If that means CPAP, or if it means intubation, then so be it. Be aggressive when it comes to airway management. Patients, female, over 30, smoker, taking birth control. Yep, that'll do it. She'll get it. Yep, Fernando, you're exactly right. The classic person who gets pulmonary embolisms is so varied that you just don't know. Some of the people that are at risk for pulmonary embolisms, birth control pills are certainly a risk factor, which is why we'd rather women would find another way of birth control. But it's convenient, it slips under the arm, it's subcutaneous, it's a pellet, it's a pill, I don't have to worry about it. Well, certain number of female patients throughout the years have died as a result of birth control pills, to the point where the Surgeon General has plastered on every single birth control mechanism out there that has to do with medications to say thromboembolism is a potentially fatal condition which can result from the use of continued birth control pills. Can't be said any cleaner than that. So when you're prescribed birth control pills, you understand the risks of those birth control pills, that it's possible. And then you put smoking on top of it, then you take a long trip, then you find out the woman is overweight by a factor of a lot. It's not just the person who's 10% over BMI. It's people that are 20 or more percent over their BMI that start increasing their risk for pulmonary embolism with the use of birth control pills as they smoke. I mean, that's just a suicide pact. So anyway, patients are treated in the scene if they're having a lot of pleuritic chest pain and they're hemodynamically stable. But you got to load these people up with IV morphine or fentanyl, whatever you're carrying. Patients that are hypotensive, they need fluid boluses real bad. Now, you may say, well, cor pulmonale, they're backing up fluid and such. And the answer is yes, of course. But once a patient goes hypotensive as a result of cor pulmonale or cardiogenic shock and such like that, you're going to have to give them at least a fluid bolus to try and maintain their pressure. Trust me, this is a bad situation to be in. The patient is the one with the disease, not you. This is something that was created with them. Subsequently, you have to do the best you can to get them out of it. Then I go to the hospital, patient from a 60 up to an 80 systolic, and then drop them at my door. I can take it from there, and we can what we're going to do from there. I've got a cabin full of pressors. I got a cardiac catheterization lab where they can go in the pulmonary artery and do clot retrieval. I can give thrombolytics in the middle of the night and dissolve the clot. Your objective is to fluid bolus them, keep them oxygenated, and get them to me as soon as you can. That's the field treatment. Okay, if you're one of those EMS systems that are progressive, very progressive, and have a good board certified ER doctor who's at the helm, they'll give you some sort of vasopressor. Most of the time it's Levophed. Why Levophed? Easy. Levophed causes the least amount of tachycardia than any other vasopressor that's out there, including dopamine. Dopamine doesn't cause much tachycardia. Dobutamine does, epinephrine drips do. But Levophed seems to be the least tachycardic patient that's out there. And we prefer it, not only for sepsis situations, but for the hypotensive situations that relate to either cardiac or non-cardiac causes, distributive shock, non-distributive shock, septic shock, such like that. We don't use it in neurogenic shock, obviously. That's a different thing altogether. We just load them up with fluids until we fill up their system. But the other shocks, most definitely Levophed is the drug of choice these days. That could change with the next article. I don't know. Medicine is always dynamic, always evolving. So anyway, we're going to go with the Levophed. And then since you arrived on seeing the patients complaining of chest pain, shortness of breath, difficulty breathing, what's the first thing we're doing for these people? Aspirin, nitroglycerin, getting a 12-lead EKG and such. These aren't likely to hurt the patient at all. The aspirin's not going to hurt them at all. And it could help start cutting down on the clot formation that's going on in the legs to begin with. Once the clots flip, aspirin's not going to have much effect on that, but you can at least get the aspirin into them. And again, you don't know if it's cardiac or not. So the aspirin's good. Nitroglycerin is not going to hurt as long as their pressure can support it. Your only absolute contraindication nitroglycerin is right-sided MIs, the posterior and the inferior walls, or pressures less than 90. You don't want to give it. But any other time you give it, and if it's the cause of their pain, it'll relieve it. The cardiac issue, if it's the cause for the pain, it'll relieve it. If it doesn't, then it doesn't. And then you keep moving on. And this is where your narcotics kind of help you out with it a little bit. Again,
Dr.
as we talked about, yes, ma'am.
Denver had a question he typed over on the right.
Oh. Back in the day when we had triples, what we called earlier in our career, we called it triple pressors. So you put a patient on dopamine, dobutamine, and then Levophed. Levophed was the last one because it was leave them dead. But that was after all three of them had been put on. The genesis for that is that once you put them on a third vasopressor to keep their blood pressure up, they're circling the drain already. And that the Levophed very rarely pulled them out of that. So it picked up an innocuous name, leave them dead. So then we got the bright idea, hey, instead of leave them dead, let's use it first. And we found that especially with our sepsis patients, that it was actually doing a great job without the death. Now, imagine putting on dopamine or dobutamine especially, which whips the heart completely in a very bad way. Imagine putting Levophed on top of dobutamine. Now you are not only whipping the heart, but you're also whipping the cardiovascular, in other words, the arteries and arterioles and such. And as a result, yeah, it would leave them dead. The patients just didn't do well. I think in residency back in the 80s, I can remember 2 patients that ever pulled out of triples vasopressors. So as time has evolved and our studies have gotten better and our monitoring has become better, but more importantly, our understanding of these mechanisms of shock have become much better. We realized that Levophed probably had a better role, not being last place and the third one hung, but the first place. And so we started using Levophed. Then we started adjusting the dosage downward a bit to 1 to 4 mics instead of what used to be the old 5 to 10 mics. So yeah, it's an old euphemism, Denver. Yeah, just stick with it as a front line. If you're part of that, one of those EMS systems that actually has a Levophed in their box, it's a pretty progressive medical director that you have, and I compliment them. Most competent systems will have a Levophed as their drug of choice now. It's replaced dopamine almost exclusively, and dobutamine. I don't know anybody who uses dobutamine anymore. So anyway, let's go back to EKG finding. Sinus tachycardia, new onset atrial arrhythmias, new right bundle branch block, S1Q3T3. These are things that we've talked about. There's no one EKG finding out there that is pathognomonic. In other words, indicates totally and completely 100% pulmonary embolism. Oh, I can tell you just from the statistics that we talked about on the previous slide, sinus tachycardia, even sinus tachycardia only occurs 47% of the time. Half the time, it's a coin toss. Are you tachycardic or not tachycardic? If you're tachycardic, you got a PE. Not necessarily. You can be not tachycardic. Tachypnea is your big one. Hypoxemia is another big one. Rails, if the clot's big enough, can be a big one. All we're talking about with pulmonary embolism is that it's real tough to diagnose it. That's probably why the second most common cause of sudden death is because you just don't recognize it. And most people are diagnosed with their pulmonary embolisms at autopsy. Bad time for a test, if that's the only test that diagnoses it. It's a tough diagnosis all the way around. It's become a lot easier with the advent of CT scan. Like I said, back in the day, the VQ scan was a 3 to 4 hour test. And, you know, by that time, the patient either came back to you, if they survived it, they were probably going to survive the pulmonary embolism. But with the advent of CT scan, helical CT scan, it's gotten a lot better. We can have an answer within 20 or 30 minutes, and thrombolytics can be on shortly thereafter. So even though there's some EKG findings that are consistent with pulmonary embolism, don't hang your hat on it. And the National Registry is not going to give you a rhythm strip and say, what has this patient got, and expect you to come up with pulmonary embolism. It just won't happen. So don't even worry about that. Okay, moving on off of pulmonary embolism, we're going to start wrapping this up now. There are some things that I wanted to talk to you about that I saw in the notes of the physicians and such that have approved questions on the version 4 and version 5 exams that you'll be sitting for. That will be your round of National Registry exams. That's going to be CPAP. CPAP has been around for a while. We see it underutilized. We think it should be used more, especially in the field. It was a very important piece of equipment that we put on the rigs some 5 or 6 years ago, and we're still not seeing as much as we should. CPAP is used to provide better oxygen to patients who are hypoxic. You put on, of course, you do easy first. Easy is going to be put a non-rebreather on, 15 liters non-rebreather. That's the first thing you start out with just about anybody, just about. And you're going to try and get their oxygen up with that. Even with pediatric patients, if stimulation and blow-by oxygen doesn't work, it's going to be a simple face mask. And if that doesn't work, you're moving right to BVM. right away before you finally decide to do the intubation. Well, that's classic PALS. That's exactly what you do with pediatrics. With adults, a little different. They're already talking to me. At least I hope they are. If they're not, they're going to get a tube right away. If you throw on blow-by oxygen on an adult, no, that's no good either. I mean, blow-by oxygen for kids that can't tolerate the face mask, and they start getting themselves so whacked out and excited that you can't get any oxygen into them. Adults, it's presumed that you'll be able to get at least a 15-liter non-rebreather mask on them. And then if they don't tolerate that, we moved to bag valve mask. Well, the advent of CPAP has changed that stage, jumping from non-rebreather to bag valve mask assistance. We now have CPAP. And the CPAP does just that. It delivers 10 to 20 millimeters of intrapulmonary pressure to not only prevent water from coming over into the lung side and causing worsening congestive heart failure, it can stop a lot of that coming across into the lung. So it's useful, it's very useful in congestive heart failure. It doesn't push water back into the bloodstream, folks. It doesn't work that way. What it does do is it pulls or it stops water from coming in to the lungs. And then what you do with your diuretic when you give Lasix is that as it gets water out of the bloodstream, then through osmotic pressure, in other words, the blood pulling the water back from the lung into the bloodstream and then gets urinated out after you give Lasix. That's the mechanism. You would think, well, water that's coming in from the bloodstream that jumps into the lungs, I should be able to push it back with oxygen pressure. Doesn't work that way. The body has to do that. We're not sophisticated enough in our respiratory apparatus yet to set up a narcotic pressure gradient that's going to pull water back into the bloodstream or force it back through 5, count them, 5 microscopic membranes that oxygen has to diffuse back and forth through for CO2 and oxygen exchange. Okay, so you're not going to push water back. Now, for the patient who's COPD, asthma, congestive heart failure, not only will it provide hyperconcentrations at good pressures, but it'll at least stop the worsening of congestive heart failure. For the asthmatic and COPD patient, it's pure benefit. It just keeps the oxygen going and going and going. Some of the COPD patients may start building carbon dioxide at that point. Doesn't matter. Your job in the field, keep the brain alive, keep the patient from going into a cardiac arrhythmia that's associated with hypoxemia, and get them into us. If your CPAP is equipped, it will allow you to attach an albuterol aerosol and you get that albuterol in, so be it, have at it. But for the most part, CPAP is a lifesaver before you have to get to intubation. Now, when you, let's get to the next slide. When you decide who is going to benefit, sentence, can you talk to me? If I'm only getting 1 to 2 words a sentence out of you and you're tripoding and you're really having a tough time struggling, you're in some severe respiratory distress. What you want to do is stop these patients before they get into respiratory failure. Once they get into respiratory failure, they're just going to collapse on you. To use this, the caveat has to be that the patient's alert and awake and obey, and they still got an intact airway reflex. In other words, if they start to gag or choke, they can clear their airway. Those are the big pillars of CPAP use. If your patient is lethargic, altered mental status, vomiting, not able to follow commands and such, CPAP is not appropriate for them. You're going to have to intubate those patients. So anybody who has an inability to open their airway, has any kind of hypotension or respiratory rate than 8 per minute, i.e. they're going into respiratory failure, altered mental status from the buildup of carbon dioxide that's in their bloodstream, now they're becoming altered, now they can't handle it CPAP's going to have to come off. You're going to have to tube these patients. As long as they can maintain a clear sensorium, you can keep on the CPAP the whole time. Or vomiting, because the CPAP is just going to allow them to vomit, go into the mask, and it's going to get sucked right back in again. So these are the contraindications, and they're going to give you a scenario. And the reason why I brought CPAP into this whole thing, as you can tell, it's an add-on to this slideshow. The reason why I brought CPAP in is because it's being questioned on version 4, version 5. In other words, the tests that you guys are going to be taking. And you're going to have to know the contraindications. The indications for CPAP are pretty clear, but they want to see if you're applying CPAP in the proper scenario. So you're going to get some 70-year-old fella who's sitting there with a chronic obstructive pulmonary disease, and they're going to describe to you very carefully that this patient is not following commands very well. He's got a respiratory rate of 6 to 8. He seems to be lethargic, he's confused, and he's trying to bat you away with his hands. One of the answers is going to be, then they're going to ask how you're going to manage this patient's airway. And one of the answers is going to be CPAP. Don't get sucked into it. If they've got these contraindications listed, your airway management is going to be intubate. Not a non-rebreather, not an albuterol aerosol. You're going to go right to intubation. Okay. All right, and then lastly, what we're going to cover real quick here, and I want you guys to pull this slideshow back down again and go over all these slides again. I know that y'all got busy lives, but this is real important, and it was painstaking putting these slides together for you based on the reviews that I've done, version 4 and version 5 of the National Registry exam. It was painstaking because over the years, as we developed these questions, there are certain topics that we want to be able to keep testing on. And what we've noticed over the past 5 years is airway management in the asthma, COPD, anaphylactic patient, congestive heart failure patient, pulmonary embolism patient, pneumonia patient. We've noticed that in all these patients, we've had varied amounts of management out in the field, which has gone from excellent to poor. And it's all over the spectrum. So the National Registry has elected to tighten that up by making airway management the focus of the next couple of exams. Doesn't mean you're going to get 90 questions on airway and then 2 on OB and you're done with the test. What it means is that you're going to get a certain flavor of scenario-based questions, which are going to involve decision-making when it comes to CPAP or intubation, or what type of airway management you would use in each of these situations. You would know that acute, chronic, chronic on chronic, acute on chronic, such like that, minor respiratory distress to respiratory arrest. This slide just kind of sums up the feelings of the National Registry. And of course, guys like me, EMS medical directors, state certified EMS medical directors, who have put forth our comments and said, hey, we're seeing paramedics coming into our emergency rooms, and the respiratory and the airway management, it isn't happening the way that it should. So your emphasis on these slides here will reflect all those feelings, and it'll tighten you up when it comes to respiratory and airway management to the point where you will pass the National Registry exam and the skills exams very competently if you know these slides backwards and forwards. All right, an acute respiratory failure. It's inadequate alveolar ventilation. You're going to get a decrease or excessively high respiratory rate. It goes back to that one, greater than 20, greater than 24. Sometimes your respiratory rates will get to 30. That's a sign of impending respiratory failure, not respiratory distress, respiratory failure. They're building up CO2. They get the CO2 out of them, or they cannot exchange a proper amount of oxygen into themselves, which is then causing CO2 to build up. That's how you get respiratory failure. There's going to be a decreased ability for the patient to expand their lungs and contract. Why? They're breathing too quickly. You can't possibly get all the air that you need to in there if you're breathing so fast. Your body is telling your lungs, breathe faster, breathe faster, breathe faster, because you're not getting enough oxygen in. And it's also telling you to breathe faster because you're trying to get excess carbon dioxide out of you. The asthmatic patient's trying to get oxygen. The COPD patient's trying to get rid of carbon dioxide. Well, what happens when they meet in the middle? The asthmatic can't get enough oxygen into them, so they're building up carbon dioxide. They're going to respiratory failure. Same thing with the COPD patient. They're already halfway there. They've already wiped out their CO2 drive. They're running on low hypoxemic, low O2 drive. So they're already halfway there. Their CO2 levels are already elevated, but they're living with it from day to day with their chronic obstructive pulmonary disease. Subsequently, it's not going to take much to throw them into respiratory failure. So any patient that comes with respiratory distress, any patient that you respond to on the scene of a home where a patient's in respiratory distress, be careful to distinguish between acute respiratory distress and impending respiratory failure. Usually has to do with altered mental status and capnography. So as part of your armamentum out there, as part of your procedure out there, before you go throwing the aerosol on them, before you go throwing the non-rebreather mask on them, throw that capnography cannula on them and start getting capnography readings. And you'll be able to tell if your COPD patient who lives in a CO2 area of about 50 to 60 is now 70 or 80. You'll be able to tell that the asthmatic be blowing off carbon dioxide is now retaining carbon dioxide. And you should know that a person who's got a 30 or 40 respiratory rate should be blowing off all kinds of CO2. But when you put the capnography on it, you figured out, oh, hey, they're not blowing off as much as I thought that they were. So they must have something going on in their lungs that's causing them to trap CO2. And that trapping means respiratory failure. And subsequently, you'll have to act differently and, quite frankly, act more rapidly. All right, I'm going to look over now. I've got the Zoom group chat up. And so we're going to talk about a couple of questions that you may have before we wrap this thing up. But go ahead and type your questions in if you have any.
Or you guys can unmute your mic and ask.
Yes.
If you don't have any questions, just type an in and hit enter, and that way we know you're not typing and we cut off before you're done.
Denver asked a question. So the National Registry, it's heavy airway. It's heavy airway management and respiratory emergencies. The next couple of versions are going to have quite a few questions related to that. Again, it's not so much you're going to see an increased number of questions as you will where the scenarios are going to be more respiratory based. And subsequently, airway management skills and controls in the respiratories will be part of those scenarios. And they're going to questions are based on that scenario, 1, 2, and 3. And one of those 3 questions is going to be heavy on respiratory management. Everything that you have in these slides right now are going to pretty much cover all of that. So you're close to taking the graduate interview, Fernando. Any tips for the medical portion of it? When you take your graduate medical interview with me, and you asked a fair question, so we're gonna talk about it. When you take your graduate interview with me, there's a trauma portion and a medical portion. And the medical portion is going to be one that has to do with it's going to have to do with an integration of respiratory and cardiac. And the patient will start out, for instance, a preview that I've just given is going to involve a cardiac component. So you're going to have, over the next couple of scenarios, a narrow complex versus a wide complex tachycardia, and being able to recognize between the two. And then you're going to be given the patients having progressive respiratory distress and difficulty breathing. And then all of a sudden your patient is going to have a need for you to intervene either in a cardiac standpoint or a respiratory standpoint. And so it's not a timing thing. I don't ask for rapid answers or else your patient's going to crump and die. It's not the purpose of the exam. The purpose of the exam is to see how well you integrate and how you think the problem through, because none of them are straightforward question, answer, question, answer. It's going to be all scenario based. So tips, you want to get all your critical actions done. So that's going to be oxygen application, cardiac monitor, oximetry, vital signs, 12-lead EKG, proper use of your EMTs on the scene that'll be used to support your particular case that you have. One of the most important suggestions and tips that I can give you is that every time you perform a treatment, you have to reevaluate the patient. Every time I pound on a hammer, I look at the nail for a second to see if I'm getting anywhere. And if after 6 or 7 whacks, the nail still looks as tall as it did before I started whacking at it, I got to think of something else. So it's the same thing in medicine. I'm going to give you a medication. I'm going to perform a treatment. Can you tell me, what does it look like? What is it? Did I have any effect on it? Then your scenario is going to progress into one of the 5 basic algorithms that has to do with resuscitation. It'll be either PEA, ventricular tachycardia with pulses, pulseless ventricular tachycardia, VFib, asystole, or you're going to have one of the unstable tachyarrhythmias, which is going to require the use of synchronized cardioversion. So you're going to have to know the difference between the two. And then your patient's going to have a need for an intubation. And so I'll be interested in hearing about your thoughts about RSI. And then we're going to get into some question and answer periods. We're going to be talking about succinylcholine versus vecuronium versus rocuronium. And you're going to tell me about the contraindications of succinylcholine. You're going to tell me why it's useful to use the non-depolarizers in patients such as those that have head injuries or high potassium levels, crush injuries, traumas, burns, and such. And we're going to discuss that. You're going to tell me mostly about how ketamine in a respiratory setting is beneficial to a patient, not only as a adjunct to intubation, but what that does for the patient's respiratory status. And as you study up on ketamine, you see that it has got bronchodilator properties. You'll see that ketamine is probably the most useful for these type of asthma/COPD patients. So there's a lot of great stuff that comes out of a medical scenario. There's a lot of things that I grade you on. Of course, being in the field the number of years that I have, and then training paramedics all the years that I have, I can give you a lot of ins and outs, and I can take you 8 different ways of Sunday on your case scenarios to see if you fully understand exactly what you're doing and why you are doing it. So that's my suggestions and tips for the medical portion of it. Of course, you can review this slideshow for this particular question and answer and dissect my answer apart right now. Anticipate which direction and what kind of medical scenario you'll be having. Yeah, like Jane tends to say, Fernando, it's the National Registry on steroids. It's a good analogy. Yeah, you get it all. All right. Well, if nobody has any further questions, then thank you for sitting with me through these 3 parts. I've thoroughly enjoyed the respiratory emergencies segment of this course. And if you guys have any questions, you can shoot me an email at jeframe@comcast.net. I'll type it up there. If there's any need to review this, again, this will be posted as soon as Jane can get it posted, and we'll be in good shape.
Okay.
All right.
Also, we have another MD roundtable with Dr. Eschelbach on Monday evening at the same time, if anybody's interested.
I hope that you all are. He's got a lot of fascinating things to talk about, and and I enjoyed listening to his perspective on such. So thank you, folks, and good night to you all, and I hope you have a great rest of the week.
Thanks all. Good night.